Okie dokie. Welcome, everybody. Boy, I'm excited today because I have two of my most favorite people in the world joining me, talking about this thing that I have never gotten my head around or my hands around or even my heart around, and that's called pain. And I think it's a fun thing to talk about because when it's significant to somebody's life and we can somehow reduce it or get rid of it for somebody, it's transformative, it's life-changing. And so I'm excited. I have Andrea Wasylow with me and Dr. Dave Tiberio. And those of you who've followed Gray Institute and Applied Functional Science realize that they're the heroes of Gray Institute and Applied Functional Science. And so we pulled out the big guns on this one just because there's so much that I don't know. And I would like to learn along with you. And like I said, it's a significant thing. We're not just talking about something that doesn't influence most of us. We're talking about something that can really change lives. So, Andrea, would you do me a big favor and just kind of introduce yourself and just let everybody know who you is and go from there?
Absolutely. I'm Andrea Wasylow. I'm a physical therapist, athletic trainer, and massage therapist. I've been doing this for about 30 years. I live up in the Northeast. I live in Massachusetts, but I work mostly in Rhode Island. I love what I do. It's an honor to help people every day, and I'm just really excited to be here to hopefully, you know, discuss pain, come up with some new ideas, and hopefully come up with some great information that's going to help people.
Wonderful. I appreciate that. Dr. David Tiberio, would you mind
Well,
introducing yourself there, good looking?
I like to start off now with saying that I'm old, which is the truth. I also am a physical therapist by educational training. Also ended up getting a PhD in sport biomechanics, but through a variety of work experiences, I happened to run into a guy named Gary Gray and been working with you for 40 years on a variety of levels and now full time at the Gray Institute, even though I'm located in Rhode Island and in a sense work remotely. But I've been doing that for coming up on 18 years. So it's been a great journey for me to be with you and then have Andrea alongside us now is great.
Well, appreciate that. I didn't want you to give those years because it makes us all feel a little bit older. So you could have just said we've been hanging out for a while, but I appreciate that. Of course, what a blessing it is as I look back to all those years. I've got to hang out with you and Andrea and just try to figure this thing called human movement out and this thing we call pain. Again, we wouldn't have a job if there wasn't pain. People didn't have pain. Very few people come in and say, I walk funny, but it doesn't hurt. Usually they come in and say, man, when I do this, it hurts. And so if you could help me, I'd really appreciate it. So if I just say pain, like when I called you guys up and said, would you honor me in being on this a podcast webinar thingamabobber, and we're going to talk about pain, what's kind of the first thing that came to your brain? Just like as soon as somebody, pain's a big, 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 big word. What came to your mind? Dave, why don't we start with you?
All right. Yeah. Well, as you know, Andrea has delved into it quite a bit and has done a number of videos for our gift mentorship program. And so that helped me along the way. But when I was dealing or digging into it a little bit deeper, I recognized that I should have been really paying more attention to it over the last 15 years. But I also realized that part of my maybe reluctance was that I didn't really understand it as well as I would like. And it sort of struck me that my understanding of pain is similar to our journey through understanding human movement. The more we learn about it, at the same time, it gives us some tools to use, but we also recognize how little we know and how much we may never know, like similar to human function. And so I think the good, bad news is we're never really going to truly understand it. But as we learn more about it, we can be more effective in helping serve our clients who have pain.
Beautifully put. Beautifully put. Andrea.
So I couldn't agree more. It's kind of like one of those ultimate oxymorons where it's a blessing and a curse. It's a blessing because it is a protective mechanism that helps us stop doing things that might create harm or damage to our bodies. But at the same time, it can also hold us back and create fear and, limit us. And so to be able to experience pain can help us, but also our systems aren't perfect. I agree with Dave in that I have more recently done a lot of learning about pain, and what I've learned in the most recent years completely kind of turned upside down my understanding of pain before. I used to think that we had nerve endings that sensed pain, when in fact we have nerve endings that sense a whole bunch of things in our environment, whether it's pressure, chemicals from an inflammatory process or an immune response, temperature changes. There's a whole host of different nerve endings to sense those things. And so our body is constantly getting information from the environment and sending that information to our central nervous system. And sometimes the central nervous system response is to create pain. So pain isn't something that we sense. It's actually something that our system produces to allow us to either stop touching something that's too hot or to stop moving in a way that could potentially cause harm. And so that kind of turned my understanding of pain upside down. And to that sense, I can't agree more with Dean. I feel like the more we learn about pain and pain science, the more we realize how much there is to learn and to understand.
Well, we can do a mic drop right there because just how you effectively, succinctly put that, that it's something that we don't sense. Hopefully everybody like me, they're obviously have deep set eyes. So hopefully you saw my eyes get picked. Like, whoa, that's how I learned it too. And so I think going on this journey today and talking more about that, it's going to be significant to all of us, but selfishly, it's going to be very, very significant to me. It's interesting. I've been to a number of courses on pain and get confused, feel humbled. And I know a big thing that people try to do is categorize pain. And even though they'll say there's an overlapping, there's no such thing as exactly acute pain, chronic pain, systemic pain, all this kind of stuff. As you guys look at pain, how in your mind's eye do you categorize it? And we'll flip it this time. Andrea, why don't you take the head on that one?
Absolutely. Because so basically, from what I've learned, there's three categories of pain. First, there is nociceptive pain, which is the type of pain you might feel where an anatomical structure is being irritated mechanically or chemically, or and that input's going to your brain and your brain senses pain in the moment. It's kind of the pain that you would expect if somebody has an acute ankle sprain or has a fracture. The next type of pain that I learned about is peripheral neuropathic pain, and that is pain that one might sense simply because there's pressure or a lack of blood flow to either a central nervous system or peripheral, or actually not central nervous, but a peripheral nervous system structure. That pain tends to be more diffuse. It tends to have a deep, achy feeling to it. There's typically patterns that go along with that. So if you look at a dermatome chart, it's essentially, if pressure is being put on the nerve root of L4, there's a specific pattern that the neuropathic pain tends to follow. And then the third type of pain is nociplastic pain. And that is the type of pain that happens when there's some type of chronic pain situation going on. And there's actually changes to the pathways within the brain that creates the chronic pain state. And so it takes, it's often those people that come in and have an 8 out of 10 pain all the time. It might have originally started in their knee, but now all of a sudden they're feeling pain at their foot and ankle, at their hip, maybe even their opposite knee. And so that is the type of pain that tends to be a little bit more challenging to work with, simply because it's almost like it presents with no rhyme or reason, except that there's this severe pain state all the time.
Wonderful. Davey, what do you think of just categories of pain and just kind of how, when somebody comes to you, how you start to organize in your mind, what kind of pain am I dealing with here?
Well, I don't think I could do better than Andrea in terms of describing the organic nature of different pain that people might feel. In the old days, the traditional way I would say, is it sharp or is it acute? Is it localized? Is it diffuse? Is it referred? And those terms that we learn can be helpful, but I think it helps to set up the rest of our discussion. If we go back a little bit, I read a definition of pain as an unpleasant sensory and emotional feeling of actual or potential tissue damage or harm. And so a couple big words there are emotional, that's added into the sensory, and then there's actual, but maybe even potential. And so that's where all the behavioral stuff that we really get into when we're now talking about movement, the things that they told us in school. You can't deal with the psychosocial, you can't deal with how the person's feeling, you're just going to deal with their movement. I think this broadening allows us to think of it in different ways and therefore be more effective, being able to attack the person from a mind, body, spirit perspective in terms of education and the behavioral as well as physical movement. Now, we want to talk about ways that maybe we can help pain. But when you think of pain initially, it's sort of like, well, pain's a good thing, as Andrea mentioned, because it prevents you from doing something that's going to harm you. And so we often, as movement specialists, talk about, well, avoiding pain. And I think our understanding of pain challenges us to modify that a little bit. We don't want to do things that are irritating the tissue and causing pain, but to be successful, we are going to have to get our clients to understand at times that reducing pain or a little bit of movement with pain may be the path to a better resolution of the problem. I hope that made some sense.
Everything you says makes sense. No, that was good. I enjoyed that. I kind of smiled because when it talked about pain and emotional, and wouldn't it be nice if we were not what we call an integrated tridoxical thing on Earth here, that we were like part of the time we could just be body, and part of the time we could only be mind, and part of the time we could just be spirit. When you kind of think about that, you go, man, that sure make treatment of pain a lot easier. Because if I don't have that mind and spiritual part in there that's messing with the pain and dealing with the pain and trying to interpret the pain and creating a whole different lens for the pain, just intuitively you go, man, that'd be a lot nicer. But on the other hand, it's no, not if that's part of pain, maybe that's a big treatment strategy of the behavioral aspect of the emotional, psychological part of helping somebody with pain. But let's talk about that for just a little bit because I think that's huge. Just Andrea, just give us some thoughts, any additional thoughts you have on what we've talked about already. Feel free to interrupt me anytime. But just when we talk about the psychological, emotional, behavioral components of pain, what, if I'm listening to this, what would you like me to know about this according to what your understanding of pain?
Absolutely. I think that, one of the things that surprised me was that people, as a physical therapist, people don't seek out physical therapy care simply because they have pain. They seek out physical therapy care because that pain prevents them from doing something that they enjoy doing or that's meaningful to them. And it's at that point when that individual loses function associated with that pain, that's typically when they seek out care. And so I think that ties in perfectly with what Dave was just saying, in that, it's the loss that people experience as a result of the pain that motivates them to try and get better. And helping these individuals, I found that the one of the strongest truths is that these people really appreciate being listened to. They often, have been shuffled around the healthcare system. They might have practitioners that kind of preemptively, without doing a thorough examination or having a thorough conversation about what's meaningful for that individual, will make treatment decisions. But if you can listen to the individual, not only will it help with your assessment of what type of pain they're dealing with, but it also helps to design a collaborative program for that individual that's meaningful for them and gives them hope. And so that's what I think of first.
Yeah, I love the word hope. Everybody, all of us need hope, and especially if you're dealing with pain. If you're sitting across from somebody that's really listening to you, and you sense that there's a glimmer of hope, that I believe that's a game changer. So that's in the huge range. What are your thoughts on that, Dave? Because you did a great job kind of bringing it up, and I know you deal very well with it. Just that whole emotional behavioral driver component.
Well, I think when Andrea kind of categorized the areas and the probably the worst, whatever that means, is the neuroplastic, the central sensitization, the actual changes in the central nervous system that occur with repeated insults and constant sensory messages coming in is going to be almost critical that we do the three E's, where we first have to engage and let them know that we're with them, as Andrew was saying, and we're listening. And then we have to, and I don't want to steal all of what we talk about, but the encourage, and then empower. But as I was thinking about it before this, I'm thinking, well, those things are still important in the other two categories of pain, just maybe not as much as this third more serious thing where everything seems to hurt and people think the person's crazy and how could everything hurt? But I'm sure that Andrea has some comments on that relative to actual things that really need to take place when someone comes in and they're in that serious state of no matter what they do, it hurts.
Yeah. Yeah, and then if they say it hurts, it hurts. I mean, at some point, early on in my career, I'm kind of, I'm not so sure about that. I would be very judgmental, which, as I'm getting older, I'm trying to be less judgmental. But to really try to, as Andrew said, listen to them and somehow, wear their shoes and walk around, so to speak. Man, the first thing I start feeling now is I really feel sorry. I mean, it's like, wow, I'm not sure. I think I'd be jumping off a bridge by now if I was dealing with that. But this person somehow trusting me to try to help them. And then all of a sudden I feel, oh crap, this is going to be tough. I know I share a story, and you guys will kind of giggle because you've only heard the story 83 times. But um, back in the day, of course, us old people, we like to talk about back in the day. But early on in my career, it was a Friday afternoon, and I thought I was finishing with my last patient. I had forgotten that my secretary told me there was somebody else out there waiting, a new patient. So first of all, I screwed up by not doing time management. And so we got this dear lady back very quickly. And I'm thinking, man, if this is just a quick plantar fasciitis kind of thing, and we can help them right now, I'm going to be a pretty happy guy. But when I pulled the chart, 8-year history of fibromyalgia and multiple treatments with all kinds of practitioners. And now I got late Friday afternoon, night, actually early evening, kind of want to get home to my dog, obviously to my wife too, and the kids. But I'm thinking, wow, I'm not sure this is good timing. But now I look at that and go, what a blessing. I mean, what a blessing that somebody would say, give it your shot, Gary. Tell me what you think's going on. Take advantage of what all the other treatment schemes have been. That's where we have a big advantage, what we find out that didn't work, and give it your best shot. And so I actually seek out people that have that chronic pain that moves around. They can't always describe, and kind of go from there. So anything else before we kind of move on to another topic of pain? Anything else, Andrea or Dave, that we need to kind of talk about relative to just the emotional part of it?
I
Well, I
think,
think Andrea, sorry, but and Andrea in one of her videos talked about the pain is real, even if it doesn't have a physical, organic thing at that stage when they're in their worst case. That it's, I used to think, as you would say, Gary, back in the day, I'm saying that can't be possible. If I'm doing this movement, that can't hurt. That would do this to that. That should put that under slack. I can't believe that would hurt. How many, can I come up with a diagnosis of a tissue that would cause all these pains? And the answer was no. And so I made the wrong judgment about what was happening with this client, and therefore I failed them. I couldn't help them.
yep, I would agree with that. And then the only other thing to piggyback on that would simply, the way I phrase it is that your system is creating the pain output, because I never want anybody to think that what I believe is that the pain's just in their head, because you're exactly right. The pain is very real. It's very limiting. And like you said, there's a strong emotional attachment to it. And so in explaining pain science, I work very hard just to make sure that the people that I'm working with do not believe that I think that it's just something that's in their head, because they most likely have heard that somewhere else along the way. So.
Yeah, and that's true. But in a way, it is all in their head. I mean, if you chop their head off, the pain goes away. So it's kind of a weird thing. But their perception, that kind of reminds me, going off tangent here a little bit, pain scales have always kind of confused me, especially when I'm asked 0 to 5 or 0 to 10, what's your pain level? And then when I'm around other people and they're asked that, and as we know, people interpret that differently. I mean, you could sit 2 people down and say 0 is you're fine, you can go out, run, have a great time. 10 is you're literally looking to jump off a bridge. The pain is so bad, you just want to get out of here. And some people very calmly say, I think I'm a 9. And you go, you don't look like a 9, and somebody else in the same situation would say, I'm a 2. And you're thinking, whoa, that's going to throw me off. So the pain scale, I think, is very important that we make it relative to the person. I don't like, well, this is 9 and this is 9, so they're same kind of people, same kind of pain. I think we have to understand what their understanding of pain is. And I found out through my career that some of that inability to effectively express their pain is my fault, that I haven't really outlined what they need to share with me to have me help me, with that kind of pain. So I know a part of what
Right,
we also, go ahead.
I just wanted to say that a couple of things I came up with is that there's such an individualistic response to pain, as you've said. And there was someone described that there's a sensitivity to the systems that are warning the body, and then there are mechanisms that are supposed to modulate this, and there's a different level of efficacy. So that these two things, the response and then the body's ability to modulate and reduce that, vary so much between individuals that we just have to respect what they're telling us and try to start from there, and hopefully find a way for movement to help them.
Yeah. Well, that's what I meant to say. That was much better. It's interesting. The last couple weeks, I've been working on a program that you guys know that I'm very passionate about. It's called Free to Play. And within Free to Play, we teach movement literacy and generosity literacy. And when I met with a consultant, they said, you need to come up with as much research on movement that you can, and as much research on generosity, giving back, helping people. And so I've been doing that. I've been, there's a tremendous amount of research out there. And what has really kind of impressed me is that all of them spend a lot of time on pain, on the effect of movement on pain. And obviously, from what we just talked about, the ability to know that somebody cares, that all of a sudden, just that understanding reduces pain. I mean, literally reduces pain. And so I think that, again, people listening to this, are the same as us. We just desperately want to know more about pain so we can help people who are in pain. But working with the body and the mind to help get rid of the pain is all we got, and obviously even spiritual pain, being able to work with them, and things as simple as forgiveness, because there's all types of pain. And I know I feel pain when I feel guilty about something. There's a pain that I feel when I'm fearful. I feel pain. So it's a tough one. So, but let's kind of zero in on kind of the pain that we deal with every day, and that's kind of the movement pain, so to speak, where okay, there's not an underlying systemic thing that's messing everything up right now, and that's kind of been ruled out. But we really have somebody that's just simply, like you said, Andrea, beautifully, I'm here not only because I have pain, but I can't do what I want to do. So when we talk about that, again, what comes to your mind, and what do you think would be something you definitely want people listening to this to understand from your perspective?
Well, I think part of what I'm grateful for in my what I've learned through applied functional science is that for each different type of pain category, applied functional science has a great overarching way to help maximize the benefits for each individual. For example, if somebody is coming in with the nociceptive pain, the straightforward ankle sprain, or the more like insidious onset low back pain, but it's relatively new. One of the things that I'm so grateful for is that my understanding, I learned from a completely different educational group, but the statement was pain is where the pathology is, the problem's elsewhere. And so I feel truly blessed to have an understanding of how to kind of do the detective work to figure out why the painful segment is being overstressed mechanically, and, getting to the why behind whatever the pain is. So I think that that's huge, because unfortunately, so many times in the literature, we've proven that physical therapy is fairly ineffective in helping people with low back pain. That is, the majority of the people come back within a year or report a return of their low back pain. And it's not necessarily because the treatment at that individual's back was ineffective. It was very helpful. Clearly, it helped that pain go away. But what doesn't always happen is that you're getting to the underlying reason why the lumbar spine is being overstressed. So for that group, I'm super grateful for my AFS background in order to be able to help figure out not only how to help the painful region, but figure out how to prevent it from coming back. Mm-hmm. For individuals with neuropathic pain, or the nerve generated pain, there's some really great techniques out there specific for that. But it's pretty standard. You can get the handouts, and it looks the same every time, and it works well if somebody's in a neutral position to do techniques, sliders or tensioners to help increase the plasticity and the movement of the nerves themselves peripherally. But once you start getting people into more functional positions, sometimes those techniques aren't enough. So again, I feel so grateful for my applied functional science background, because I can then take the individual who's done really well with the conventional techniques, and then can move them into a more functional position for the task that they are desperately trying to get back to, and treat the neurogenic pain specific in that transitional zone, or in that position that they're going to find themselves in when they're functioning. And then specifically, like we've talked about already, with the nociplastic pain, to help somebody through movement. Movement is part of their medicine. Absolutely 100%, because their pain has been so severe, because their fear of moving is so severe, to help them understand that hurt doesn't necessarily mean harm to the tissues, and to help gently design a movement program that builds on success, figure out what they are more comfortable doing, and build on those movements to then move towards more challenging movements or positions. Again, anchoring to that principle, one of the many principles that I've learned through applied functional science, just makes me really grateful when I'm trying to help these individuals with pain.
Wonderful. That was a great. Dave, I want you to add to that, but then I'd like to come back, and because some people are out there going, what is applied functional science? And, I think there's a misunderstanding that it's this new science that is a technique, and that, where we realize it's just the truth of human movement. And as you said, a lot of the things that we've learned traditionally blend in perfectly with it. It's not like,
Exactly.
hey, that's not what you want to do. Is, yeah, no, you might want to do that first, and then get them into more extremes, and then be able to start understanding the cause of the problem. That'll start showing up more, and still use manual therapy techniques to facilitate the movement as well as facilitate the inhibition of pain. So we'll come back to that, but I kind of want Dave to kind of talk about and just add a little bit to what you shared.
Yeah, all the things that Andrea described, and basically those three different things where we would work in different ways, we can always create a movement that I believe will be beneficial. We may not know what that's going to be before we start working with the client because we listen to them as what they're describing to us, but we also listen to their bodies as they move. But if you have a localized injury, a nociceptive thing, well, certain movements with an ankle sprain are going to be fine and necessary, while others may need to be avoided for a little bit. So we have to understand chain reaction biomechanics. It's not just a global movement. And at the Gray Institute, we're really good at three-dimensionalizing everything because we want to cover all our bases. But once we learn how to cover all the bases, we learn that some movements in some planes in some directions are better than others. And so we apply those at the right time, understanding the chain reaction biomechanics that helps get rid of the ecchymosis that's going to become a chronic thing that's going to stimulate those sensory nerve fibers. And if we have a neural tension thing, we know we have our 3D maps and our fascial 3D maps fascia, and we can decide whether we want to move to release tension on the nerve if it's really acute. Well, as it improves, we're then going to start to move in a different direction. That's going to create subtle little tension. And when we're using global movements, we can use different drivers because in AFS, we learn about all the different drivers. And then certainly in that last case that Andrea was describing, again, in her video, she talks about it may not be the number of reps, but just giving the person a goal of doing something for so many seconds. And when they complete that, whether they've done a half a rep or 4 or 5 reps, they can be encouraged because they've been successful. And so I think we need to recognize that when someone has pain, there are probably movements that we want to avoid. But just as important is to recognize there are some that we must give to our client as a tool to empower them to get better.
Wonderful. Great job. Andrew, just build upon that, but then talk a little more about how, what is AFS? That's a question that some people might have. And why is it very similar to what we've all learned, but why is it a pinch different?
So my brief elevator speech when somebody asks about AFS and what applied functional science is essentially, with the exception of a class here and there, because I was fortunate enough to have Dave as a professor when I was in PT school. But what I learned in PT school was essentially how the body functioned floating in space. The hamstrings flex the knee, your abdominals flex the trunk. And what I am so grateful for is the work that you and Gary, you and Dave have done to bring that body down to earth. So now you are actually looking at how the body functions with gravity, ground reaction force, mass, and momentum, and taking all of that into consideration across every different position that the body might get in every environment, whether it's a water environment, on land, or like jumping in the air. And things are going to look differently when you're in the air and airborne compared to what you're doing on the ground. So that is just my elevator speech, because it really changes how the whole body and the whole system works when you actually integrate a total body approach with the forces that we experience here on Earth.
Yeah, very well put. I've never heard that analogy. I like it. Kind of the space thing, as a spaceman, you're floating around and you don't have to deal with this on Earth stuff. And there's a big change. And obviously we sometimes just say, well, if you lay somebody down on a table, what happens with the body, the pressure and forces and all the perceptions that we have are extremely different than when we stand and walk and move. And so I think one of the things that we've all been working hard on in applied functional science is what is the dynamics of a human being while moving here on Earth. And because most of us didn't learn that, we just didn't learn it. And so once we learn it, because people will tell us, get rid of the pain so I can, they don't say, get rid of the pain so I can go to space and float around. They go, help me get rid of this pain so I can go back and play pickleball. I had a cute little young lady today that I saw. She says, get rid of this pain on the inside of my ankle so I can go back and play soccer. Okay, well, that's a pretty good goal. But then we got to figure out where's that coming from. Now, I know the tissue was a posterior tib, but the real question that you would bring up, Andrea, is what's causing it? So, and she had been to therapy now for almost a year, a little bit frustrating. They've been trying to treat the symptom. They never once asked this question. Gee, I wonder why in this dear young lady that her posterior tib doesn't want to heal. And so initiating the understanding of how that body functions when she's playing soccer is key, as opposed to just saying, well, I think this is the posterior tib, we should do this and this and this. What would your thoughts be there, Dean? Dean, obviously, Dave's the dean of our applied functional science program called GIFT. And so I know he's thrown a bunch of elevator speeches at people, but what would you want people to understand about AFS as it relates to pain? We're obviously talking about pain here, and why I think getting a better understanding of functional human movement is significant for anybody who has to deal with people that have pain.
I think Andrea hit on a bunch of those, but you know that we, and you've been the chief architect of that, we've put a lot of these things that we have to pay attention to, as much science as we can find, into the three buckets of the physical, the biological, and the behavioral sciences. And so, you know, when Andrea's talking about gravity and ground reaction forces, we're talking about the environment that we exist in, and then how the body reacts to that, and all the parts that we'd like to think we know about how the muscles work and the nerves work and the proprioceptors, et cetera. And then the behavioral, which for all of us is becoming so much more important, that we really need to understand our clients and where they're coming from, and not only to get them engaged in what we want them to do, but how much that influences how their body works. That pain will influence the way their muscles work. It will affect their autonomic nervous system. It isn't just something that they sense, but that it has a negative output into some of the motor responses. And so sometimes the quickest way to get a better movement is going to be not only to address the behavioral, but certainly be working on how we can do that relative to their pain.
Wonderful. Anything to add to that, Andrea?
No, Dean, I think that Dave summed it up great in what he just said. The only other thought that I had is I just part of, again, integrating the behavioral science, but education is a huge part of helping these people feel better. You know, I recently read a study by Dr. Adrian Lau. It's a single case study, but they did a functional MRI of an individual with chronic low back pain, and the MRI beforehand, at resting state, while moving, and then after receiving education about, you know, what is going on with their pain, and how hurt doesn't necessarily mean harm. And in summary, in that one case study on the functional MRI, the pain centers of the brain were actually able to quiet simply with education and understanding. And so I think, like, it goes back to speaking, if you're educating somebody about their pain, you can't do that without listening to them and listening to exactly where they are and helping them understand the processes in their body. And simply by doing that, you can really help an individual move forward to living with less pain and moving more comfortably.
That's powerful. And I think we underestimate ourselves as movement professionals, our ability to just use the verbal things coming out of our mouth to educate people and giving them an awareness. Besides the whole idea of engagement, encouragement, empowerment, just so what kind of bed do you sleep on? You know, how often do you sit? Do you look at the TV in that direction? When you get in your car, how's your seat? Have you thought about this? Get them part of the process of figuring it out. I find out that my patients love that, and they don't expect me to figure it out. They're very kind, and I go, we got to figure this out together. I don't live with you, so I don't know what's going on. So the more you can tell me, and then hopefully I can transform that into some education, as you said. And I think that proves just the educational part is powerful with these patients. It's quite significant. Years ago when I did see a patient that just had chronic pain, again, a diagnosis of fibromyalgia, whatever that is. Don't even want to open that bag of worms right now, but I just seen the dear lady's eyes, and the white part was yellow, and just seeing her demeanor, I mean, your heart just aches. And so whatever your approach is, the approach I took was to find out, as you guys have said, a movement that she could do that didn't seem to exacerbate. And strange enough for her, it was far, far away. So she had a lot of upper quadrant pain, posterior neck pain, high thoracic pain, upper trap pain, just about anything, just any movement of her neck like that. I'd say, can you describe? Oh, that hurts. You know, that's very painful. And the benefit I had is all of her therapy, strange enough, has been localized to that area. All kinds of stuff, you know, sticking needles in, doing ultrasound, doing stim, doing manual therapy, doing soft tissue work, doing traction work, everything there, where just basic common sense would say, get away from that. and see if there's a part of their body you can move that still will feed the thoracic spine, the cervical spine, the scapula, and the shoulders, and all the associated muscles, and of course, all the associated nerves. And first of all, find out where she can be successful. And I remember doing this with a dear lady years ago, and she you'd kind of expect her to say, "What the heck? Why am I doing this? Why am I doing lunges, so to speak, in three planes of motion?" But I just simply explained to her. I said, part of what we got to do is get you back to doing what you want to do, and that's movement. So I got to figure out what movement might help you, and more importantly, help inhibit that pain and get that part of your body. So we're going to go ask some friends. All of our body parts have friends. So we're going to go downstairs and ask some friends, and so she was very successful at doing a frontal plane lunge. So her home exercise program was, do me a favor, do these side to side lunges. Okay. If it does increase any of your discomfort or pain, please stop. However, if you feel okay, your goal is to see if you can go out a little further and maybe just a pinch faster, just a little more rhythm to it. And I can't remember how many days it was, but let's say it was over the weekend. She came in on Tuesday. And the very first thing I did, I could see in her eye, there was a little glimmer. And I think it's important that we don't delve on the pain. Instead of say, how are you feeling? I simply said, so how did you do with your side to side steps? And her comment was, well, pretty good. And I said, would you mind showing me? She said, well, I wanted to show you. She wanted to actually show off that she was going out a little further and she's going a little faster. And I remember I had just learned from my wife sign language that said, I am proud of you. So I thought, well, I am proud of her. And so I got eye to eye level with her. And I said, I need to share something with you. And hopefully you're taking this, that it's coming from my heart. And I said, I am proud of you. She had no idea what I just said with my hands. And I said, so would you mind if I shared with you what I just shared with you via sign language? She goes, no, I appreciate that. And I looked at her and I simply said, I am proud of you. A huge emotional response. I mean, instantaneously. And so I thought, and I'm not going to tell you all my failures, but this one turned out to be a huge success where she turned into what we called a matrix mama. I mean, by the time she got out of there, she was literally lifting light weights in all three planes of motion and just basically nicknamed herself the Matrix Mama. But the point is, I then do that with everybody now. If I can find out something successful and I can empower them to do it at home, and I can basically teach them how to tweak it to make it a little easier, harder, and then give them an opportunity to show off. Okay, they're not showing off, they're just showing me what they did. And then share with them in one way or another how proud I am of them. So far, out of, I would say, hundreds of patients with that kind of thing over the last 50 years, an immediate emotional response. So I've never had anybody go, yeah, you're proud of me, big deal. Because the question is, how long has it been since somebody told her that they're proud of them? When you're dealing with that kind of pain, it not only influences you, but the entire family, and, the spouse or the friend or somebody just feels, we feel terrible when we can't get them feeling better, and we're supposed to be the experts at that. Imagine what a husband or wife feels like when like they come home and how you doing? I feel like crap. But pretty soon that just beats you up. So I don't know, just that, I think we looped around a little bit there on the behavioral part. So we've got some amazing people out there, hopefully still listening. And what I'd like you guys to do, and Dave, I think I'm going to bias you a little bit, because I remember one of the significant things I learned from you over the last couple of years is understanding proprioceptors and understanding the proprioceptors in the skin and nociceptors, and finding out that there are techniques where I can get those guys who normally convey pain, or interpret, as you would say, not sense pain, Andrea, but actually let us know that there is pain there, where that can be transformed into an actual nerve that says, no, I don't feel pain anymore, I feel pressure. So why don't we start with you, Dave? Just say, hey, you know what? I want to share this, but the bottom line is I'd really like to share with other professionals who care as much about pain as we do. Here's what I'd like to share with them.
Well, you don't want me to go into the hour and a half presentation, but
Sure.
the quick message is free nerve endings that are the most abundant in the human body, that are said to either be noxious or nociceptors, those that sense pain. But then there are all the others that don't sense pain. They're for telling us where we're moving, the relationship of one body part to the other, what happens when we move and the skin changes and lengthens. These free nerve endings are in fascia. They're in all kinds of connective tissue. And so some of the adverse studies would suggest that if we leave ecchymosis in an area, if we don't get it moving, that more of these free nerve endings are sensing or are interpreted in the brain as producing pain rather than just movement. And so it shows that we need to be moving as quick as possible. And then hopefully, once we get to work with this client, we're able to then get that movement where they either don't get into the situation or it reverses the situation so that we're back to having the stimulus that's coming from this area not be interpreted as a dangerous sensation, but rather a part of normal movement.
Beautifully put. That was quicker than an hour and a half. Obviously, the hour and a half version is. I remember when last time you gave it last year, you got a standing ovation, and I told everybody in the audience that I think you're going to look back upon this lecture as life changing for you and your patients, because when we start realizing the benefits of putting our hands on people and creating the right, what we call functional manual reaction, the right reaction to tissue and movement, and getting rid of crap under the skin, and talking with our hands to the fascia and talking with movement to the fascia, that literally we've been given these God-given things that go, guess what? I'm not going to interpret pain anymore. I'm just going to be a pressure sensor, and I'm going to let you know where you are. Boy, that's huge. I mean, that's in a huge range. And so that gets very encouraging for those of us who really like to utilize a kind of a manual approach to soft tissue function and movement function of not only the area they have the pain, but areas away that might be causing that limitation, might be causing that abnormal pain. So beautifully put. Andrea, obviously the gift fellows get 40 weeks benefit from you to, allow you to share a lot of this stuff. And we're trying to smash it in like 45 minutes here. But what would you kind of, in conclusion, just say, man, I want to just share with those who are listening to this that, this is kind of what I think about. Here's kind of what I want to emphasize. And here's maybe the frontier that we need to still look at for all of us in the future.
Well, just to kind of share a few different resources. Again, this is knowledge that I've been learning about more recently, probably within the last 5 years, and it has really opened my eyes to new ways and a new understanding for helping individuals who have pain. If you're looking for a real quick hitter, a 15-minute TEDx talk, there's one by Mortimer Mosley called "Why We Hurt." He's an Australian gentleman, and it is he's hysterical, but he's a neurobiologist, I believe, and he describes his own pain experience, and it's just a really great way to kind of get from somebody with that level of expertise and understanding of why we hurt. If you want to do a little more work about learning about pain neuroscience education, the person I referenced earlier, Dr. Adrian Lau, is a great reference. But for me, for anybody with any type of pain, movement is medicine. And no matter what, I have done a lot of education, and I'm thrilled to be a lifelong learner, but I have discovered that across all my experience, there's no better place to learn how to understand human movement in order to help people, especially people who have chronic pain, short-term pain, than learning at the Gray Institute. At the Gray Institute, I'm grateful to have been able to study for decades, and am incredibly grateful at the gifts that I've learned, the information that I now have, the strategies that I use every day to help these individuals, and to be able to integrate the information I have about pain science and then use that to develop movements that are going to, be precisely prescribed for the individual in front of me and for what's important to them. There's no better gift to help these people. So.
Well, it's a two-way street. We've been blessed because of your passion, because of your wisdom, because of your yearning, just want to continue to do better and to give every patient, every client an equal opportunity to receive world-class treatment. And so very kind of you to say, but a big part of that is you and the blessing you've been to us. So I just wanted to make sure that everybody understood and appreciated that. What are your kind of last thoughts there, David T?
My last thoughts are, I agree with what you said about Andrea. And when we're humbled by our lack of knowledge, we're then able to really open up our ways of thinking about things. It's when we think we've got it all figured out that we limit our ability to serve others.
Yeah. I think a neat way to kind of conclude this is hopefully that those who are still listening, it's obvious they care a lot. Most people don't listen to us, and that doesn't mean they don't care. It just means that that's interesting. But I think it's important that those people who have dedicated their lives, like you and Andrea, to understanding the human movement system, that we realize that there's very few other professionals that impact pain and impact fear and impact guilt as well as you all do. And I want people who are listening to this to challenge themselves to realize that they are, to let me know somebody other than themselves that does a better job transforming pain into a degree of comfort, and transforming, obviously, guilt into compassion, and transforming fear into confidence. Those listening to this, that's what you do every day. You're a transformer, and you're transforming lives. And just the fact that you want to know even a pinch more about pain, and obviously a lot of you know more than we do about it, but it means a lot to us that you would be kind enough to hang in there with us and listen to us, and kind of be a part of what we're trying to pursue. So I got a strong feeling the feedback we're going to get is that, hey, we need more cowbell. And so we're going to need more of Andrea and more of Davey T ringing the cowbell about pain. But I've enjoyed this dramatically. I knew I would, but it's kind of neat when you enjoy it a lot. But I just want to thank you both, and I want to thank those who are listening. They're the real heroes here. They're the ones out there, like you guys are, on the street, taking care of people. And what a blessed job we have, where people come to us in pain and just simply say, hey, do your best, but I'd really like to be able to play with my grandkids, or I'd really like to be able to do that again. So if you could help me, I'd really appreciate that. So blessings to you all. Thank you again. Awesome job. And we'll be back with this. And so just know how much we appreciate you. In fact, I'm going to say I am proud of you too. So thanks again.